So next is fistula in ano. What is fistula in ano? It's a fistula in ano is a hollow tract lined with granulation tissue connecting a primary opening inside the anal canal to a secondary opening in the perineal skin. Secondary tracts may be multiple and can extend from the same primary opening. What are the causes of the anal fistulas? So chronic cryptoglandular disease, Crohn's disease, tuberculosis, pulmonary disease, head retinitis suppurativa, trauma, foreign bodies, and malignancy. How do you classify them? So I will use the past classification. You might be asked to draw a diagram. So most common is 70% intersphincteric fistula. The tract passes within the intersphincteric space, and then transsphincteric fistula 25%. The tract passes through the external sphincter into the scrotal fossa, and then suprasphincteric fistula 5%. The tract passes above the pubic and then curls down through the levator and the scrotal fossa. Then extrasphincteric less than 1%. The tract runs without relation to the sphincters, often passing from the rectum above the levators. How do you manage a transsphincteric fistula? EUA assess the location of the internal and external opening, course of primary tract, presence of secondary extension and the disease that might complicate the fistula, drain the infection, and if the tract can lay it open without risking the incontinence, then I would lay it open. If the fistula cannot be delineated, I would request an MRI to evaluate the fistula. And subsequent surgical options once the infection is under control include fibrin glue, collagen plug, advancement flap, paste, lift procedure, ligation of the internal intersphincteric fistula, waft video assisted anal fistula treatment, and FELAC laser and stem cell injection. Treatment option would depend on the anatomy of the tracts. If laying open the tract leaves behind the sufficient sphincter, the patient is male and has no pre-existing bowel dysfunction, lay open could be considered. How do you classify perineal disease and Crohn's disease? So it's a huge classification of perineal disease. Primary lesions, secondary and incidental lesions. Primary lesions are anal fissure, ulcerated inward spile, cavitating ulcer, aggressive ulceration. Secondary lesions, skin tags, anal rectal strictures, perineal sepsis, fistula, and carcinomas. And then incidental lesions, hemorrhoids, perineal abscess, fistula, skin tags, cryptitis, retinitis suppurativa. What are the treatment options for Crohn's perineal fistula? So first one is the medical therapy needs to be optimized and treatment should be planned in conjunction with the gastroenterologist. And then surgical treatment aims to drain the sepsis, place a loose draining ketone. And if the fistula is high, options should include a plug or a waft to control the symptom, or deafening stomach may be required if symptoms are severe. A loose draining ketone can be used to long term to palliate the symptoms. And in severe cases where all other treatment failed and the disease is resistant to maximal medical treatment, a proctectomy may be required. Thank you.